Welcome to Explain, a series of health education programs published by the Patient Education Institute, the leading provider of interactive health education. This video includes general medical information and does not replace the medical advice of your doctor or healthcare provider. If you have questions pertaining to your medical condition, ask your doctor or healthcare provider. Transoral Odontoid Resection. Introduction. Neck pain is a common condition that affects many people. In rare cases, it can be caused by a deformity or malformation of the upper neck. A part of the second vertebra of the neck, also known as the odontoid, may get displaced and press on the brainstem or spinal cord. This can lead to weakness, paralysis, numbness, decreased sensation, and possibly death. Your doctor may recommend an operation to remove the odontoid. This operation is called transoral odontoid resection. The decision whether or not to have this surgery is also yours. This patient education module will help you understand the causes of this disease, as well as the benefits and risks of this procedure. Anatomy. The brain controls all body functions, such as movement, sensations, and thinking. The brain is located in and protected by the skull. This is the brain stem. It connects the brain to the spinal cord and it controls breathing as well as the muscles and nerves of the face. This is the spinal cord. The spinal cord is located in and protected by the spine. The brain stem and spinal cord connect the brain to the rest of the body. The spine is formed by solid vertebrae. The vertebrae are separated by softer discs. The top two vertebrae of the spine have a different shape from the rest of the vertebrae. The topmost vertebra is known as the atlas. It is rounded with a big hole in the center. The second vertebra is known as the axis. The axis has a part in the front that sticks up in the shape of a tooth. This bony structure is called the odontoid process. The odontoid fits in the front part of the whole of the atlas, in front of the spinal cord. There are no discs between these two vertebrae. The atlas and axis are kept in place by strong tissues called ligaments. The spinal cord and the brain are surrounded by a special fluid known as cerebrospinal fluid, or CSF, shown in blue on the right. This fluid acts as a shock absorber. The spinal cord, brain, and CSF are surrounded by a special membrane known as the dura, shown in red on the right. This membrane helps protect the spinal cord and brain. It also prevents the CSF from leaking. Symptoms and their causes. The odontoid may move out of place and push on the spinal cord and brainstem. This is known as spinal cord or brainstem compression. This can lead to weakness, paralysis, numbness, decreased sensation, and possibly death. Several diseases could lead to the displacement of the odontoid. Arthritis is one of the most common causes of the displacement of the odontoid. Arthritis is caused by the inflammation or wear and tear of the joints and ligaments. Sometimes the odontoid is either deformed or out of place since birth. These are called congenital abnormalities. These abnormal vertebrae are usually present at birth. The slippage may worsen over time, explaining why some of the symptoms do not show up until later in life. Arthritis and congenital abnormalities can lead to weakening of the ligaments that keep the first two vertebrae in place. In turn, this weakening may lead to the slippage of the odontoid and compression of the spinal cord, the brainstem, or both. Sponsored by the Patient Education Institute. www.patient-education.com. Over 5,000 videos and interactive tutorials. Other treatments. Sometimes your doctor may recommend an operation that does not include removing the odontoid. The back part of the skull and upper part of the neck are sometimes fused to correct and prevent further slippage of the odontoid. Fusion means attaching the skull and the first two neck vertebrae to each other with bone and possibly screws, wires, and plates. However, sometimes your doctor determines that fusion is either not an option or not good enough a treatment. If the symptoms are serious and if the fusion is not recommended or is not sufficient, an operation to remove the odontoid becomes mandatory. To take out the odontoid, the best way to reach it is from the front, through the mouth. Procedure. The aim of the operation is to take the pressure off the brainstem and spinal cord by removing or resecting the odontoid. The operation is done through the mouth or oral cavity. Transoral means to go through the mouth. The operation is called Transoral Odontoid Resection because it means removing the odontoid by reaching it through the mouth. This operation is done under general anesthesia. The anesthesiologist puts the patient to sleep and inserts a tube in the patient's mouth into the trachea to help with the breathing. Sometimes the breathing tube inserted in the mouth is in the way of the surgeon. In this case, the surgeon may decide to make an opening in the neck to allow the patient to breathe from this opening. This procedure is called a tracheostomy. During a tracheostomy, a small incision is made in the front of the neck and taken down to the breathing tube or trachea. The trachea is then opened and a smaller tube is placed in the trachea. The tracheostomy tube may be kept in place for a few days after the operation while the swelling of the tongue goes down. After the operation, the tracheostomy tube is removed when the patient is able to breathe on his or her own. This may take a few days to a week depending on how much the tongue swells after the operation. To reach the odontoid, the soft palate in the top and back part of the mouth may have to be cut in the middle. The surgeon then opens the back of the mouth. The distance between the odontoid and the back of the mouth varies from 1/4 inch to approximately an inch. The surgeon removes the odontoid by cutting it with special tools and drills. A microscope is usually used during the odontoid removal. Sometimes the odontoid may be stuck to the dura, the membrane that covers the spinal cord and the CSF surrounding it. If the odontoid is stuck to the dura may be opened and some CSF may leak during the operation. If this happens, the surgeon may take some fat and or muscle from the patient's belly or leg to patch the leak. After the operation, in case of a CSF leak, a tube called a lumbar drain may also be put in the patient's back to drain CSF in a special bag. This diverts the CSF away from the mouth incision and allows that incision to heal. The lumbar drain is usually kept for a few days. By removing the odontoid, the surgeon decompresses the spinal cord and brainstem. In other words, the pressure is taken off the spinal cord and brainstem, allowing these structures to recover and heal. After the spinal cord is adequately decompressed, the back of the mouth and the soft palate are sutured. The patient is then allowed to wake up and taken to the intensive care unit, the ICU, for further observation. Risks and complications. The surgery is relatively safe. There are, however, several possible risks and complications. These are unlikely, but possible. You need to know about them just in case they happen. By being informed, you may be able to help your doctor detect complications early. The risks and complications include those related to anesthesia and those related to any type of surgery. Risks of general anesthesia include nausea, vomiting, urinary retention, cut lips, chipped teeth, sore throat, and headache. More serious risks of general anesthesia include heart attack, stroke, and pneumonia. Your anesthesiologist will discuss these risks with you and ask you if you are allergic to certain medications. Blood clots in the legs can occur due to inactivity during and after the surgery. These usually show up a few days after surgery. They cause the leg to swell and hurt. Blood clots can become dislodged from the leg and go to the lungs, where they will cause shortness of breath, chest pain, and possibly death. Sometimes the shortness of breath can happen without warning. It is extremely important to let your doctors know if any of these symptoms occur. Getting out of bed shortly after surgery may help decrease the risk of blood clots in the legs. Some of the risks are seen in any type of surgery. These include infection, deep or at the skin level. Deep infections may involve the spinal cord or the fluid that circulates around the spinal cord and brain. This is known as meningitis. Treating deep infections may require long-term antibiotics and possibly another operation. The incisions inside the mouth may get infected and open up. The same could happen to a thigh or belly incision in the rare case that this incision is made. CSF may also leak from the mouth. This may necessitate another operation and the placement of a lumbar drain. Bleeding could occur either during or after the operation. This may necessitate a blood transfusion and the possibility of another operation to take blood clots out. Other risks and complications are related specifically to these procedures. These again are rare, however it is important to know about them. Strokes and hemorrhage may occur inside the brain, brainstem, or spinal cord. They could lead to paralysis and even death. However, they are rare. The two main aims of the operation are to prevent further dangerous compression of the spinal cord by the odontoid and to improve the symptoms. However, there is always the possibility that removing the odontoid may not improve the symptoms. In rare cases, the patient's symptoms may even become worse after the removal of the odontoid. After the surgery, patients may spend 1 or several days in the intensive care unit for observation. It is normal for the tongue to swell a lot and cause some breathing difficulties. That is one of the reasons for keeping the regular breathing tube or tracheostomy tube for a few days after the operation. The swelling improves within a week. If a tracheostomy is not done, the surgeon and anesthesiologist may decide to keep the breathing tube going from the mouth to the trachea for a few days until they are sure the patient is able to breathe on his or her own. While the tube is in the trachea, the patient is unable to speak. Breathing may also be regulated by a respirator. This is normal and should not be a cause for worry. If a tracheostomy is used, the patient may also not be able to speak for a few days. A few days later, a different tube may be placed in the tracheostomy to allow the patient to speak. Once the swelling of the tongue improves, the tube to the trachea is taken out. If a tracheostomy is done, the hole in the neck closes in a matter of a few days. The only trace of the tracheostomy is usually a small puckered scar in the middle of the neck. Until the incisions inside the mouth heal, patients are fed with a small feeding tube. This feeding tube is inserted through the nose or mouth and goes into the stomach. The nurses in the intensive care unit watch very carefully over the progress of the patient by checking temperature, pressure, movements, sensations, and other signs. After the stay in the intensive care unit, the patient is transferred to a regular room where he or she will stay several days depending on the patient's condition. Physical therapy may be needed to improve the patient's function. Depending on the patient's condition, a stay in a rehabilitation or extended care facility may be needed to speed up recovery. If you like this video, please like and share. For similar videos, subscribe to our channel. Summary. Compression of the spinal cord and/or brainstem by the odontoid is a serious condition that may lead to paralysis and even death. Transoral Odontoid Resection is an involved operation to remove the bone and take the pressure off the spinal cord. This operation produces good results and is safe. Risks and complications are not frequent. Knowing about them will help you detect and treat them early if they happen. Thank you for using Explain.